talking about complex regional pain syndrome, which is one of the commonest syndrome seen in following a lower and radius fracture. This is a clinical picture of a old lady wherein post lower and radius casting, she presents like this, wherein there is a swelling, there is shiny skin, inability to flex the fingers. Then after this, there is the questions, 5 questions which the surgeon and patient is worried about. Who is responsible? Whether it is the patient, surgeon, is it related to the hand or brain? Does patient need medicine, surgery, physiotherapy or psychologist? And whether it will be curable, and whom to consult and whom to refer. These are the common questions which the surgeon and patients encounters. Now surgeon's dilemma is, if he has done pinning, he is worried whether the entry point was right, wire length was right, number of wires, post fixation, mobilization, whether the plaster was removed on time, rehabilitation instructions were followed, whether he had given or patient didn't follow. Now, what is complex regional pain syndrome? It is a complex syndrome, usually occurs typically after trauma to the wrist, presents with severe pain at rest with the slightest movement. There will be swelling, vasomotor instability will be there, functional impairment of the affected limb, wherein there is a reduction of the movement and the strength, grip strength is reduced. And it will be either with type 1, that is presence of type 1 without a presence of nerve injury, and type 2 where there is a discrete nerve lesion. Now there is a because of lack of understanding of the etiology and pathogenesis of the condition, there always exists a confusion. So this has led to a plethora of names, which Waldman in 1996 had described some 67 English terms for the same one condition. These are the list of names, how it was called as synonymous of complex CRPS. Now it is classified basically in 2 types. One is type 1, where there is no injury, which was formerly called as reflex sympathetic dystrophy, and the type 2, which is associated with a nerve injury, formerly was called as causalgia. Now, is it related to the hand or the brain? Now, this is the pathophysiology of CRPS 1, wherein initially there will be injury to the hand, wrist I mean. Then the original injury initiates a pain impulse carried by sensory nerve to the central nervous system. This initiates the sympathetic chain of nerves in the spinal cord. This again triggers a pain reflex response, establishing a cycle of pain and swelling. Now, what is the etiology specifically in type 1? In type 1 or type 2, whatever it is, we invariably ask the patient to in the cuff and collar sling, but ideally it should be above the heart level. Second thing is, whenever we put a cast, the cast is normally that it should not cross the distal palmar crease. Thumb should be free. Full extension of the digit should be there. Proximal cast should not touch the elbow crease. This is the wrong way of putting the cast. Now, etiology in type 1 and type 2. Normally in distal radius and CRPS, in type 1, etiology is due to tight cast. Sometimes there is a tight bandages or this thing, that is compression of the median nerve, instability of distal DRUJ and the ulnar, lower end of the ulnar fracture. In type 2, etiology is invariably the pinning of the distal radius fracture, and over destruction of the external fixator causes the nerve injury. Now, in CRPS type 2, there are 3 superficial nerves around the wrist and 2 deep. Most most invariably the superficial radial nerve, palmar cutaneous nerve, branch of median nerve, dorsal cutaneous branch of ulnar nerve, they, they are involved. See, whenever we do a blind pinning in the lower end of radius, most probably the superficial radial nerve gets impinged in between. And if patient is not comfortable using the hand after pinning, there is a high chances that he might develop a CRPS, wherein you have involved a pricked the nerve ins. The second is palmar cutaneous nerve of the median nerve, which is around whenever we do a volar surgeries. It is origin is around 5 to 7 centimeters proximal to the proximal wrist crease. Here you can see the arrow, the lower arrow shows the palmar cutaneous branch of median nerve. And the third one is the superficial nerve is dorsal cutaneous branch of ulnar. Now mostly it is caused due to iatrogenic injury, wherein when we try to fix the ulnar styloid fixation, it comes in the way. Second is whenever we try to fix the DRUJ joint from ulnar side, then also it might get involved. And when we are repairing a TFCC ligament also, it might get damaged. Now types of CRPS, CRPS 1 and 2. In the type 1, there will be no precipitating event. We have only casted the patient. Whereas in type 2, there is a precipitated event is present. Mostly we have done a pinning or a external fixator. Nerve injury, there is no involvement of any nerve injury in type 1. In type 2, there is a nerve injury involved. In clinical features, there is spontaneous pain in type 1. Different skin temperature is invariably increased, and hyperalgesia. Hyperalgesia means that sensations are very, you'll get hypersensitive. Now in type 2, from the beginning only there will be burning pain. Allodynia means there is on superficial touch also it initiates a pain and is hypersensitive to pain. The symptoms are invariably progressive in type 1, and in type 2 the damage is caused once, so it is non-progressive. In type 1 you see X-ray changes. Invariably we see osteopenia, and in type 2 there are no bony changes. So this is a patient wherein the left side is the affected side. We have got a shiny skin. The wrist is hand is swollen. Intolerance to temperature, cold temperature. There is diffuse pain, and mobility is restricted. Male to female ratio is 1:3. See, this is an X-ray picture in type 1, wherein you can see on the right side there is a diffuse osteopenia, soft tissue swelling will be there, and old fracture will be seen. Now, there is an International Association of Pain, Study of Pain, Budapest Diagnostic Criteria for Complex Regional Pain Syndrome, wherein there are 4 categories, and then all of the categories must be met. First one is continuing pain that is disappropriate to the inciting event. The one sign in 2 or more of the categories below. One symptom in 3 or more of the categories. There are 4 categories actually which is mentioned down. And no other diagnosis can be better explain the sign and symptoms. Now how to prevent it? This is how we diagnose it. Prevention is in type 1. We should encourage the early mobilization. Elevation should be above the heart. We should start vibration and desensitization. Stiffness treated with gentle movement. And in type 2 prevention, while passing K wires, take a small incision on the styloid. Retract the soft tissue and then hit the styloid and pierce the K wire. This is how the proper cast should be. The elbow should be free. MCP joint should be free. thumb should be free, and there should be strict elevation. So we should start physiotherapy from the beginning, wherein we should start from the shoulder to prevent the shoulder hand syndrome. Now, what are the treatment options? It is a multi-disciplinary approach should be taken, wherein the surgeon, physiotherapist, psychologist, and pain specialist should be involved. Now, surgeon's role here later on is medical line of treatment, wherein he has to start NSAIDs, pregabalin for 8 weeks, vitamin C, calcium for 8 weeks, oral alendronate 40 mg for 8 weeks, IV ketamine SOS if it is very painful in low doses. This is the references for this. And now coming to physiotherapy, that hand therapy, we have to address the whole limb, because there is also might be shoulder hand syndrome that also had to be taken care. Range of motion, that is active and passive. Stress loading activities which will be taught by the physiotherapist. TENS, desensitization technique, sensory re-education, and combination of therapy. This is after the therapy and treatment. There is one more, that is mirror visual feedback, wherein which involves the patients hiding the affected hand behind a mirror. The patient sees their normal hand and also its mirror image, where the patient sees it as if it was the affected limb. Exercising the normal hand looks to the patient as if he is exercising the affected limb. The visualization of the moving mirror image, which the patient sees as the affected hand, usually encourages the patient to move their real affected hand movement. This is usually done even to prevent phantom limb also. Now, treatment for acute phase of CRPS. First is physiotherapy. Initially, we can start with steroid, then calcium, and pre-radical scavengers such as mannitol. For chronic CRPS, specific physiotherapy, mirror therapy, stress loading. Patient has to be counseled that it will take time. Drug therapy like steroids, gabapentin, antidepressants. Then TENS, spinal cord stimulation, sympathetic blocks. Surgery, if there is any nerve compression and all, to decompress, and sympathectomy. Treatment for refractive CRPS is reserved for patient because the results are highly variable. Surgical sympathectomy can be done. Stellate ganglion block by the pain specialist. To conclude, in type 1, we should not only bombard physiotherapy to the patient. Consider medical management along with physiotherapy and counsel the patient for 4 to 6 weeks. Stellate ganglion blocks or cervical sympathectomy are well-known treatment, but seldom done. And in type 2, identify the nerve involved, whichever the nerve is, whether superficial or deep. Mostly conservative treatment can be tried along with physiotherapy, and if nerve symptoms are causing, then nerve surgery can be considered. Thank you.